Hi everyone, welcome back to Contraception, and in this segment of Contraception, I will be talking to you about estrogen and progesterone containing contraceptives. Now, in estrogen and progesterone containing contraceptives, majorly I will be talking about the oral combined pills, the types of pills, their mechanism of action, the composition of the pills, then method, how to take the pills, what are you going to do in case of missed pills, the contraindications, important concepts, and non-contraceptive benefits. But other than the oral combined pills, I will also be talking about vaginal rings and transdermal patch in brief, right? Let's start with estrogen and progesterone containing contraceptives. We have three estrogen and progesterone containing contraceptives. One is the oral combined pills. These are not oral contraceptive pills. These are oral combined pills which have estrogen and progesterone. Then we have transdermal patch which have got again estrogen and progesterone, and then we have vaginal rings which contain estrogen and progesterone. First, I'm going to talk to you about the oral combined pills. Now, in oral combined pills, there are two ways of saying, when we are classifying oral combined pills, there are two ways of classifying them. Number one method is to combine them in terms of their dosage, whether it's a high dose pill, a low dose pill, or a very low dose pill. Now, whenever we are talking about the dose of the pill, basically we are talking about the estrogen component. We are talking about estrogen component, that is how much estrogen is present in that pill. So a high dose pill is when estrogen, and the most commonly used estrogen in an oral combined pill is ethinyl estradiol. That's the most commonly used estrogen in an oral combined pill. So if ethinyl estradiol, it is more than 50 micrograms, then such a pill is called as high dose pills, and a high dose pill is not used these days. Right? A low dose pill means when ethinyl estradiol is less than 50 micrograms, generally the dose is 30 micrograms. Very low dose pills means when it is less than 20 micrograms. And also remember that the minimum effective dose of estrogen in a pill is 10 micrograms, and we have a pill which has 10 micrograms of ethinyl estradiol of estrogen, and that is Loestrin. So Loestrin has estrogen around 10 micrograms. Right? This is one way of classifying the pills. The other way of classifying pills is based on the generation. And whenever we are saying generation of pills, we are talking about the progesterone component. Whether progesterone belongs to first generation, second generation, third generation, or fourth generation. Now, when I was doing gynae pharma integration, there also I told you that the most important generations are third and fourth generation progesterones, because as the generation increases, the androgenic side effects of progesterone keep on decreasing. So first generation progesterones will have a lot of androgenic side effects, second will have a little less, and third generations, they have least androgenic side effects. Fourth generation are anti-androgenic. Now in third generation progesterone, so whenever we are talking about third generation pills, a third generation pill will have third generation progesterone. And what are third generation progesterones? These four, they should be there on your fingertips. The third generation progesterones are gestodine, norgestimate, desogestrel, and etonorgestrel. So gestodine, norgestimate, desogestrel, and etonorgestrel, these are third generation progesterones, and a pill which has got a third generation progesterone will be called as a third generation pill. Now remember, the most commonly used progesterone these days is desogestrel. This is the most commonly used progesterone in an oral combined pill. Now when we are talking about fourth generation progesterones and fourth generation pills, fourth generation progesterones, they are anti-androgenic. Right? They are anti-androgenic, and they have got drospirenone, drospirenone. Now, drospirenone is a derivative of spironolactone. Drospirenone is an aldosterone antagonist, and because it's an aldosterone antagonist, what it is going to do is it will have a diuretic action. And all of you know that estrogen, it leads to salt and water retention. So if I am using drospirenone as the progesterone component, because drospirenone has a diuretic action, it is going to antagonize the salt and water retention which is caused by estrogen. So many times when you are giving oral combined pills, because of this salt and water retention, there may be mild hypertension. So if your patient has got mild hypertension when the patient uses oral combined pills, rather than stopping the oral combined pills, it's better that you switch them over to a fourth generation pill containing drospirenone. Similarly, if your patient has salt and water retention when she is using an oral combined pill, it's better that you use a fourth generation pill containing drospirenone. The other important applied aspect which you have to remember is, because drospirenone has a diuretic action, it is going to lead to excretion of sodium, but then it is going to lead to retention of potassium. And that is why in patients who have got renal failure, you should use them very, very carefully. Now, drospirenone, as I'm telling you, it has got anti-androgenic action. They may ask you that how does drospirenone have an anti-androgenic action? Drospirenone has an anti-androgenic action because it increases sex hormone binding globulin. And all of you know that androgens, they majorly bind to sex hormone binding globulin. So if sex hormone binding globulin is increased, the levels of free testosterone will be decreased, and that is how it has an anti-androgenic action. So, apart from drospirenone, a fourth generation pill can have Dynogest. Dynogest is also a fourth generation progesterone, or it can be Nomigestrel. Right? So Nomigestrel, Dynogest, drospirenone, all of these are fourth generation progesterones, and pills which have got fourth generation progesterones are called as fourth generation pills. Now, as I told you, most common progesterone used in contraceptives these days is desogestrel. Clear? Okay. Now, what is the mechanism of action of pills? Now, see, pills have got estrogen and progesterone. Estrogen, all of you know, it has a negative feedback on GnRH. So because it has a negative feedback on GnRH, estrogen will decrease GnRH levels. Now, because the levels of GnRH would be decreased, the levels of LH and levels of FSH will be decreased. And because levels of LH and FSH are decreased, there will be an ovulation. So if someone asks you what is the main mechanism of action of oral combined pills, the main mechanism of action of oral combined pills, it brings about an ovulation. Now, this an ovulation is mostly because of the inhibition of FSH rather than in LH. So, more prominent action for this an ovulation is FSH rather than LH, because if the levels of FSH are decreased, the follicles will not grow, and if follicles will not grow, definitely there won't be any ovulation. Although an ovulation is a combined result of decreased LH and FSH, but if they ask you which one is more important for bringing about an ovulation due to the pills, then more important for an ovulation due to pills is inhibition of FSH more in comparison to inhibition of LH. Now, this is one and the most important mechanism by which a pill is going to act. But other than that, a combined pill will also have progesterone, and because it is going to have progesterone, this progesterone will make cervical mucus thick. And when the cervical mucus will become thick, then the sperms will not be able to enter, right? They will not find it very easy to enter. That is why, this is another method of bringing about contraception by the pills, and that is by making cervical mucus thick. Then the next method is it decreases tubal motility. The progesterone component decreases tubal motility, and that is also one of the mechanisms which adds to its contraceptive action. And then because we are giving oral combined pill where there is estrogen and progesterone, we all know that progesterone has anti-proliferative effect. So when you give progesterone, it brings about thinning, decidualization, It brings about decidualization of the endometrium. And because there is decidualization of the endometrium, this endometrium is not suitable for implantation. Right? So initially there will be decidualization of the endometrium followed by thinning of the endometrium. Right? And this kind of endometrium is not suitable for implantation. These are additional methods by which a pill brings about contraceptive action. But the main mechanism of action is by bringing about an ovulation. Let's talk about composition of some very important pills, in which the most important composition you should know is composition of Mala D and Mala N. Please remember, Mala D and Mala N both have got same composition. Both of them have got 30 micrograms of ethinyl estradiol and 0.15 mg of levonorgestrel. Both of them. Right? So both have 30 micrograms ethinyl estradiol and 0.15 mg of levonorgestrel. Then what's the difference between Mala D and Mala N? The difference between Mala D and Mala N is Mala D is sold by the government of India at subsidized rates. Whereas Mala N means no cost, right? So Mala N is distributed free of cost by Government of India. That's the only difference, right? Otherwise, composition-wise, both of them have 30 micrograms of ethinyl estradiol and 0.15 mg of levonorgestrel. Right? Then comes Yasmin. Remember, Yasmin is a 4th generation pill. It has got 30 micrograms of ethinyl estradiol and it has got 3 milligrams of drospirenone. So you just have to remember compositions of Mala D, Mala N and Yasmin. Now, how to start a pill? How are you going to advise your patient to start a pill? Pill should be started either on day 1 of the cycle, or you can start it between day 1 to day 5 of the cycle. Now, when you are starting either on day 1 of the cycle, and when do you say it's day 1? The day a female starts having bleeding, that becomes her day 1 of that cycle. Right? So either you start on the day of bleeding, that is day 1, or you start between day 1 to day 5. In both these cases, no backup method is needed. No backup contraception is needed. But suppose a female is starting oral combined pills after day 5 of the cycle. In that case, yes, an additional contraceptive method would be needed for one pill. Now, one pill has to be taken daily, roughly around the same time. And in a pill, generally there are 21 tablets. So for 21 days, a female will have to take tablets. 21 days means for 3 weeks. So for 3 weeks, continuously, she will be taking one pill a day. And then she's going to stop the pills, right? Because the pack would get over. Now, once this female stops the pills, what is going to happen? Now, when she was taking the pill, estrogen and progesterone, this synthetic estrogen and progesterone had gone inside her body, and this synthetic estrogen and progesterone had an inhibition on the natural LH and natural FSH. So in the female's body, natural LH and FSH levels had gone down. And because natural LH and FSH levels had gone down, there wasn't any ovulation. There won't be any natural progesterone in her body. There won't be any natural estrogen in her body. Whatever estrogen and progesterone this female is taking is in the form of that pill. So for 21 days, she's taking the pill. So till 21 days, the levels of estrogen, this estrogen and progesterone which you are giving, the synthetic estrogen and progesterone in her body are high. Natural estrogen and progesterone are not there. Now, after 21 days, when she stops taking the pills, the levels of estrogen and progesterone would go down. And because the levels of estrogen and progesterone would go down, she will now menstruate after 3 to 4 days of stopping the pills. Now, once she again has her menstrual cycle, that first day of bleeding will become day 1 of the cycle, and again she will put herself on the pill. Have you understood how to advise giving pills to a patient? So it has to be given continuously for 3 weeks, and then there has to be a break. Now, sometimes what happens is that patients, they forget to take pills. And when they forget to take pills, the levels of estrogen and progesterone in their body goes down. And because the levels of progesterone goes down, that results in a breakthrough bleeding. So the most common side effect of a pill is breakthrough bleeding, because the person who was taking the pills has forgotten to take the pill, right? Now, in order to reduce the chances of breakthrough bleeding, these days, instead of a 21 pill pack, there are certain pills which have got 24 pills. So now a pack with 24 pills is also available, and the only advantage of a 24 pill pack is that the chances of breakthrough bleeding are less with a 24 pill pack rather than a 21 pill pack. Have you understood? Right? Now, if you've understood that how a pill has to be taken, you will understand that all the non-contraceptive benefits of the pills are also because of the way you are giving the pills. Now, because of the way we are giving the pills, that means you are giving pills for 21 days, then you are stopping, then again you are starting from day 1 of the cycle. You are trying to regularize the cycles. So, oral combined pills, they can be used in females in whom the cycles are irregular. So that's one of the non-contraceptive benefits of oral combined pills. Number 2, now if your patient is bleeding, if she is having heavy bleeding, when you are going to give her pills, what is going to happen? You are giving estrogen and progesterone. Now, because you are giving estrogen and progesterone, what is going to happen? Estrogen is going to induce receptors of progesterone on endometrium, and the moment you give progesterone supports the endometrium and the bleeding stops, right? So in all patients who have excessive bleeding, you can prescribe them oral combined pills. Number 3, because oral combined pills are making cycles anovulatory, and anovulatory cycles are painless. So yes, oral combined pills can also be used in females who have dysmenorrhea or who have endometriosis. Please do not write all this, because I'm going to make you write all this. Just understand this concept. Once you've understood the concepts, writing is very easy. I'm going to make you write each and every non-contraceptive benefit. But over here, I just want you to understand. Just understand why there are so many non-contraceptive benefits of oral combined pills. Right? Then, suppose there is a female who has hyperestrogenic condition. Right? Now, in all hyperestrogenic conditions, if you are giving an oral combined pill, what is going to happen? This oral combined pill is going to inhibit LH and FSH. The natural LH and FSH gets inhibited. And if natural LH and FSH gets inhibited, natural estrogen will not be produced. And if natural estrogen is not produced, then the hyperestrogenism is controlled, right? Because now what you are giving to her is only 30 micrograms of ethinyl estradiol. On the other hand, she was producing a lot of estrogen. So when I'm giving oral combined pills, I am inhibiting the natural estrogen. Body's natural estrogen is now no longer produced, and whatever estrogen is there in her body is just this pill. Whatever amount of estrogen this pill has got, she has got only that much estrogen. Right? So yes, in hyperestrogenic conditions like, fibroid, endometriosis, again, you can use oral combined pills. In fibroid and endometriosis, oral combined pills are going to be helpful in decreasing their blood loss. Right? Now, suppose if I ask you, oral combined pills are going to decrease the incidence of which cancers? You are going to say, ma'am, all those cancers which are due to hyperestrogenism, their hyperestrogenic conditions, all those cancers, their incidence would be decreased if a female uses oral combined pills. And what are those cancers? Endometrial cancer and ovarian cancer. So chances of endometrial cancer and ovarian cancer, they are decreased because when you are giving oral combined pills, natural estrogen is inhibited. Are you understanding this? Yes. Now, because an oral combined pill, when you give, it inhibits LH and FSH, and it is LH which acts on theca cells to produce androgens. Right? So, if there is excessive androgen production, for example, if there is hirsutism or if there is PCOS with hirsutism, again, you can use oral combined pills for managing that hirsutism. Are you understanding, all of you, the non-contraceptive benefits? Why oral combined pills has so many non-contraceptive benefits? Clear? Okay. So, since I have talked to you about the non-contraceptive benefits, so let's write the non-contraceptive benefits first, and then we are going to do what is going to happen if pills are missed. So, what are the cancers whose incidence is increased with the use of oral combined pills? What are those cancers whose incidence is decreased? And what are those cancers where there is no effect if oral combined pill is used? So the incidence of hepatic adenomas is increased. Number 2, incidence of breast cancer, especially, there is a slight increase in incidence in premenopausal females with breast cancer. And number 3, cancer cervix. So there are 3 cancers: hepatic adenomas, then breast cancers, especially in a premenstrual female, premenopausal female, not premenstrual female, and number 3, in cancer cervix. Remember, in cancer cervix, the risk is reversible, which means as long as a female is using oral combined pill, till that time the risk is there. Once she stops using the pills, the risk is no longer there. Right? Now, in which conditions is the use of oral combined pills beneficial? That means it is going to decrease the incidence of which cancers? As I told you, it is going to decrease the incidence of endometrial cancer. It is going to decrease the incidence of ovarian cancer. Not only ovarian cancer, it will also decrease the incidence of ovarian cyst. Then, use of oral combined pills decreases the incidence of benign breast diseases. It slightly increases the incidence of breast cancer, but it decreases the incidence of benign breast diseases. And then it decreases the incidence of colorectal cancer. So these are 5 conditions which are relieved when you are giving oral combined pills. I'm repeating them for you. Number 1 is endometrial cancer. Number 2 is ovarian cancer. Number 3, ovarian cyst. Number 4, benign breast diseases, and number 5, colorectal cancer. Then there is one cancer which has no effect. Neither is the incidence increased, neither is the incidence decreased, and that is liver cancer. Why I am mentioning it here is because so many times you tend to get confused between hepatic adenomas and liver cancer. Incidence of hepatic adenoma is increased by the use of oral combined pills. But as far as liver cancers is concerned, oral combined pill doesn't have any effect on the incidence of liver cancer, right? Then, what are the non-contraceptive benefits of oral combined pills? Non-contraceptive benefits, number 1 is because the oral combined pills are going to make cycles regular. So yes, they are used in patients with irregular cycles where they are the drug of choice. In PCOS patients, they are the drug of choice, right? So I don't know whether you watched the video on PCOS or not. In PCOS, I have told you that normally in a patient of PCOS, the symptoms, the drug of choice depends upon the symptoms. But if a plain simple line question is asked, a single line question is asked that what is the drug of choice for PCOS, then you have to say that the drug of choice for PCOS is oral combined pills. Right? Number 2 non-contraceptive benefit is that oral combined pills, they decrease menstrual blood loss. And because they decrease menstrual blood loss, that is why they are beneficial in patients of atypical uterine bleeding, endometriosis, and fibroid. Number 3, oral combined pills makes the cycle anovulatory. And all of us know that anovulatory cycles are painless. That is why oral combined pills are used for managing primary dysmenorrhea, where again they are the drug of choice, and for managing pain due to endometriosis. Because they make the cycles anovulatory, so functional ovarian cysts, they are also used for managing functional ovarian cysts and menstrual migraine and Michel-Merz syndrome. So all these pain problems, there are 3 or 4 pain problems, and one is functional ovarian cysts. So if there is primary dysmenorrhea, if there is Michel-Merz syndrome, endometriosis, or menstrual migraine, these are again the non-contraceptive benefits of oral combined pills. Oral combined pills helps in relieving these problems. Now, oral combined pill is also used for managing premenstrual syndrome, but please remember, it is not the drug of choice for managing premenstrual syndrome. For managing premenstrual syndrome, the drug of choice are SSRI, that is selective serotonin reuptake inhibitor, fluoxetine. But yes, it can be used, but the drug of choice is fluoxetine. Then oral combined pills have got estrogen and progesterone. Estrogen component is used as HRT and in management of Turner's syndrome. All symptoms of menopause are due to estrogen, right? So because oral combined pill is a combination of estrogen and progesterone, so yes, oral combined pills are used as HRT and they are used in managing Turner's syndrome. Now, because it has progesterone and progesterone makes cervical mucus thick, so yes, oral combined pills, they help in decreasing the chances of PID, in decreasing the chances of sexually transmitted diseases, and in decreasing the chances of ectopic pregnancy. So please remember that oral combined pills, they lead to a decrease in the incidence of PID, salpingitis, and ectopic pregnancy. Now, one very important thing which you have to remember about OCPs and PID is that it's a very, very controversial topic, right? Some studies say that, with the use of oral combined pills, the chances of PID are increased. Some say that because it has got progesterone and progesterone makes cervical mucus thick, so overall the chances of PID are decreased. So the general consensus is that yes, it is decreasing the chances of PID. But if a question is asked to you that what is the most common PID which is seen after the use of oral combined pill, then the most common PID with the use of oral combined pill is chlamydia. And if they ask you which is the most common vaginitis which occurs after the use of oral combined pills, then the most common vaginitis which occurs is candidiasis, right? Continuing with the non-contraceptive benefits. Now, because oral combined pills are decreasing GnRH, in turn, they are decreasing LH, and because LH acts on theca cells to produce androgens, so if levels of LH are decreased, the levels of androgens would be decreased. That is why oral combined pills are drug of choice for managing hirsutism. They are also used for managing acne and hyperandrogenism. So these are all non-contraceptive benefits of oral combined pills. If you have a look at them and if you've understood the concept, I don't think so you will have to mug up this. As far as cancers are concerned, this table definitely I want you to remember it by heart, because many questions are asked related to oral combined pills and cancers. Right? Now let's go back to what happens if a female misses a pill. Now suppose a female comes to you and she says that I have missed one pill. Now, if she has missed one pill, she should take the missed pill ASAP. The moment she remembers that yes, she has missed a pill, she should immediately take it and she should resume her schedule. No backup is needed. This is if she has missed one pill. Right? So the moment she remembers that yes, she missed a pill, she should take that pill and she shouldn't be using any backup method, and then she should resume her normal schedule. But suppose if a female says, I have missed two pills. Now, if a female says she has missed two pills, you have to see whether these two pills are missed in the first and the second week of the cycle, or whether they are missed in week 3 of the cycle. If they are missed in week 1 or week 2 of the cycle, she has to take 2 pills for 2 days and she has to finish the pack. Right? So if a patient misses 2 pills, and these 2 pills are missed on week 1 or week 2 of the cycle, she has to take 2 pills for 2 days. And she doesn't have to start a new pack. She has to continue with the same pack and a backup has to be used for 7 days. But if your patient says that she has missed 2 pills in week 3. Now, if she misses 2 pills in week 3, she should start a new pack. And she should immediately use a backup for 7 days. Now she has to start a new pack, right? So if she is missing 2 pills in week 3, you are going to tell her, okay, stop using that pack, start a new pack, take 1 pill daily, and for 7 days use a backup. Same thing you are going to advise if a female says that she misses 3 pills at any time. Are you understanding? So missing pills, you have to see whether it's one pill which is missed, whether it's two pills which is missed, or whether it's three pills which is missed. If one pill is missed, she has to take that one pill as soon as she remembers and she has to resume her schedule normally, right? No backup is needed. But if she is missing two pills and these two pills are missed in week 1 or week 2 of taking the pills, right? So in week 1 or week 2, the moment she remembers this, she has to take two pills for 2 days. She has to continue the same pack and she has to use a backup for 7 days. If she is missing two pills in week 3, or if she is missing 3 pills at any time, then you tell her, okay, throw away whatever pills are left in the previous pack. From today onwards, start a new pack, right? And use a backup for 7 days. Have you understood? Now, if pills are used in a perfect manner, then the failure rate of pills is 0.1%. That's very less failure rate. But then if you are using typically, not in a very perfect manner, then the failure rate is 8%. Clear to all of you? Okay. Now, what are the absolute contraindications of oral combined pills? The absolute contraindications of oral combined pills, you can remember it with a mnemonic, that is, banks have various schemes to provide home loans during May, right? So, banks have various schemes to provide home loans during May. Now, in banks, the B stands for known or suspected cases of breast cancer. So if your patient is a known or a suspected case of breast cancer, then this is an absolute contraindication for using oral combined pills. Please remember, this is the most important topic from where questions are asked on pills. Right? They will ask you, they will try to confuse you in many ways. So each and every word which I have written for absolute contraindications, which is also WHO category 4 contraindications. Right? So this, each and every word of this table is very important. Then H stands for uncontrolled hypertension. Please pay attention to this word uncontrolled. Uncontrolled hypertension, which is severe, is an absolute contraindication. Severe means BP should be 160 more than equal to 160 by 110. Remember, medically controlled hypertension is not a contraindication for use of oral combined pills, right? So medically controlled hypertension, mild hypertension is not a contraindication. It's uncontrolled severe hypertension which is a contraindication. Right? Number 3 is undiagnosed vaginal bleeding. Undiagnosed vaginal bleeding is an absolute contraindication. Then S stands for smoker who's more than 35 years of age. But then I'm not saying any female who's more than 35 years of age is an absolute contraindication. No, I'm telling you smoker. And if she is more than 35 years of age, then that's a contraindication. Then T stands for known or a suspected case of thromboembolism. So if your patient is a known or suspected case of thromboembolism, because you know that estrogen component increases the clotting factors, right? So that is why it's absolutely contraindicated. It's an absolute contraindication. Not only this, if there is family history of idiopathic thromboembolism in parent or sibling, then also it's an absolute contraindication. Or if your patient has history of cerebrovascular accidents, MI, or conditions predisposing to it, right? So this is very, very important contraindication. A known or a suspected case of thromboembolism. If there is family history of idiopathic thromboembolism within parent or sibling, or if there is history of cerebrovascular accidents or MI or conditions predisposing to it. Now, what are the conditions which predispose to thromboembolism? So if your patient has malignancy, or if your patient has lupus anticoagulant, or if there is prolonged immobility due to trauma or surgery. Again, these are absolute contraindications for using oral combined pills. Then comes pregnancy. Definitely pregnancy is an absolute contraindication. And apart from that, if there is history of peripartum cardiomyopathy, please remember this is a newly added contraindication for oral combined pills. So peripartum cardiomyopathy is an absolute contraindication for using oral combined pills. Then if there is severe hypercholesteremia or severe triglyceridemia, right? So severe hypercholesteremia or severe hypertriglyceridemia hypertriglyceridemia. When we say severe hypertriglyceridemia, it means more than equal to 750. Then if patient's presently her liver function is impaired, or if she has a liver cancer, or if she has acute or chronic cholestatic liver disease. So presently impaired liver function, liver disease, liver cancer, or if she has acute or chronic cholestatic disease, that's an absolute contraindication, right? Past history of hepatitis, it's not a contraindication. Yes, presently if there is hepatitis, definitely the liver functions will be abnormal, so that becomes an absolute contraindication. Right? Then diabetes with vasculopathy, not any type of diabetes. Diabetes specifically with vasculopathy, right? So if they say diabetes is an absolute contraindication, no. Right? Only diabetes with vasculopathy is an absolute contraindication. Similarly, migraine with aura is an absolute contraindication. Then in breastfeeding females, yes, it's an absolute contraindication. And in postpartum females for less than 20 days, it is an absolute contraindication, because in postpartum females, even though they might not be breastfeeding, at less than 21 days, it's an absolute contraindication. Why? Because in postpartum females, still the levels of clotting factors are high and it can predispose to thromboembolism. Right? So these are all absolute contraindications for use of oral combined pills, in which you can remember all of them with the help of a mnemonic. Banks have various schemes to provide home loans during May, right? So breastfeeding and postpartum female, this is another thing which you have to remember, that yes, they are an absolute contraindication. Clear to all of you? Now, I know this is clear to you, but still there will be certain confusing points which they are going to ask you, and they will tend to confuse you, and many of you will get confused with it. For example, if they say smoker who has quit smoking for less than 1 year. So, for example, they say that there is a smoker whose age is more than 35 years and for past 3 months she has not been smoking. So is it an absolute contraindication? Yes. Please remember, from smoker to be called as non-smoker, the time interval has to be 1 year. Right? So if the smoker has quit smoking for more than 1 year, then that's not an absolute contraindication. But if smoker has quit smoking for less than 1 year, then yes, it's an absolute contraindication. Similarly, if there is a female who's more than 35 years and your person is on nicotine gums. Nicotine gums is again an absolute contraindication for using oral combined pills. Now, if they ask you that history of thromboembolism is an absolute contraindication, is varicose vein an absolute contraindication? No. Varicose vein is not an absolute contraindication. No age is an absolute contraindication, and obesity is also not an absolute contraindication. When I said age, it was a smoker more than 35 years of age. I did not say that any female who's more than 35 years of age cannot use oral combined pills. But yes, although they are not absolute contraindication, in females who are older and females who are obese, we prefer using progesterone only contraceptives. It is not this that in obese females and in older females, oral combined pills is an absolute contraindication. No, it's not an absolute contraindication, but we prefer using progesterone containing contraceptives. Now, there are 3 important relative contraindications which you have to remember. One is sickle cell disease, another is gallbladder disease, and third is SLE. These 3 are important relative contraindications: sickle cell disease, gallbladder disease, and SLE. Now, in SLE, suppose your question says that there is a patient of SLE and lupus anticoagulant is present. Now, the moment they say that lupus anticoagulant is present, then it becomes an absolute contraindication. Clear? Continuing with some important concepts. So if your question says that presently your patient has hepatitis, now if presently your patient has hepatitis, her LFT would be abnormal. So till LFT becomes normal, yes, present hepatitis is an absolute contraindication. But is past history of hepatitis an absolute contraindication? No. Past history of hepatitis is not a contraindication. Then females with factor V laden mutation. Females with factor V laden mutation, they have increased chances of embolism, and again that becomes an absolute contraindication. Now, females who are on anticoagulants. Females who are on anticoagulants, that's not an absolute absolute contraindication, but if your patient is on anticoagulant, we prefer using progesterone-containing contraceptives. Similarly, congenital heart disease is not an absolute contraindication. Now, if congenital heart disease is predisposing to thrombosis, yes, then it becomes a contraindication. But otherwise, congenital heart disease is not a contraindication for using oral combined pills. Similarly, patients with CIN. Now, because I told you that oral combined pills can predispose to cancer cervix, so if they ask you patients with CIN, is it an absolute contraindication for using oral combined pills? No. Now, whatever contraindications I have told you, these are from the latest edition of Leon Spiroff. Right? You are not going to rely on PARC for contraception. For contraception, I want you to rely solely on what I am teaching or what Dr. Mukmehut might have taught you, right? Because I am teaching from Leon Spiroff. I am not referring to PARC, and for contraception, you have to know the latest concepts, and latest concepts are based on Leon Spiroff's latest edition. Coming to return of fertility. When does fertility return after stopping oral combined pills? So fertility returns within 3 months of stopping the pills. In which condition is oral combined pill the contraceptive of choice? Oral combined pill is a contraceptive of choice in a newly married couple who are staying together. Right? Number 2, it is a contraceptive of choice after H-mole evacuation, and it is contraception of choice for spacing the pregnancy. So in these 3 conditions, yes, definitely it is the contraceptive of choice. Clear? Now coming to other estrogen and progesterone containing contraceptives, and in other estrogen and progesterone containing contraceptives, number 1, we have the rings. Now please remember, when we are talking about rings, when we are talking about transdermal patches, all 3 of them, their mechanism of action is same. So if they ask you what is the mechanism of action, the main mechanism of action is they bring about anovulation. Then their absolute contraindications are same. Right? So I'm not going to repeat to you the absolute contraindications and the mechanism of a transdermal patch and of a vaginal ring. Let's talk about these rings. This is a vaginal ring and it has got estrogen and progesterone. Now there are 2 kinds of vaginal rings which are available in market. One is the Nuva ring and the other is Anovera ring. Nuva ring, it releases 15 micrograms of ethinyl estradiol per day, whereas Anovera ring, it releases 13 micrograms of ethinyl estradiol per day, number 1. Number 2, progesterone, which Nuva ring has got is etonorgestrel. And the progesterone which Anovera ring has got is segestrol. And a Nuva ring is going to release etonorgestrel 120 micrograms per day, whereas an Anovera ring, it releases segestrol 150 microgram per day. Now, this is the compositional difference between Nuva ring and Anovera ring. But then there is one major difference between Nuva ring and Anovera ring, and that is how it has to be used. See, when you are using, whether you are using Nuva ring or whether you are using Anovera ring, you have to put the ring on day 1 of the cycle. So on day 1 of the cycle, you are going to put the ring or insert the ring. You're going to ask the female to insert the ring in her vagina, and this is how the ring is inserted in vagina, right? So once the ring has been inserted in vagina, this ring has to be there in the vagina for 3 weeks, whether it's a Nuva ring or whether it's Anovera ring. The same ring has to be there in vagina for 3 weeks. After 3 weeks, the ring is removed. So there is, for 1 week, no ring has to be there. 3 weeks, the ring has to be there. 1 week, the ring is not to be there. Now, in that 1 week period, like you give a pill for 21 days and then you stop giving a pill. Similarly, over here, for 3 weeks, the rings would be inserted in vagina. After third week, the third week has ended, you are going to ask the female to remove the ring from her vagina. Right now, when she is going to remove the ring from her vagina, bleeding is going to happen in 2 to 3 days. And when she has the day 1 of next cycle, in case of Nuva ring, a new ring has then to be put. She has to put a new ring, and this new ring is now going to be there in place for 3 weeks. Have you understood? But in case of Anovera ring, the same ring can be cleaned and it can be put back. Right? So aloe vera ring, it can be used like this for 1 year. When you are using aloe vera ring for 1 year, how are you going to use it? You are going to insert it for 3 weeks, remove it for 1 week. Then again insert it for 3 weeks and remove it for 1 week. Have you understood? Yes? Okay, so common sense tells me that with Nuva ring and aloe vera ring, the advantage over oral combined pills is that they have better compliance. Rings have better compliance than pills, right? And because they have better compliance, there will be less chances of breakthrough bleeding. So the chances of breakthrough bleeding will be less. Now, there could be a female who says that, ma'am, when I am using this ring, it creates a problem during sexual intercourse. So can I remove it during intercourse? Yes, they can remove it during intercourse. The only thing is that after intercourse, it has to be reinserted within 3 hours. Within 3 hours, the rings have to be reinserted. If they are inserted within 3 hours, then no backup is needed. No backup contraception needed. Right? But if it is reinserted after 3 hours, then you have to advise her that a backup contraception has to be used for 48 hours. Is that clear? A very, very important contraindication of aloe vera ring, which is not a contraindication of Nuva ring, is it is contraindicated in females with BMI more than equal to 29. Right? So in obese females, it is contraindicated. This is all what you need to know about Nuva ring and aloe vera ring. Mechanism of action, their absolute contraindications, everything is similar to oral combined pills. Now, similarly, you need to know a little bit details about transdermal patches. Now, a very important difference between transdermal patch and rings is rings were inserted continuously for 3 weeks, right? And then 1 week off. Over here, a patch, you are going in one pack, there will be 3 patches, right? 1 patch per week. So every week a patch has to be reapplied. And this way, for 3 weeks, you have to apply patches, then 1 week off. Then again, for 3 weeks, you have to apply patches in such a way that every week a new patch has to be applied. Now, this is one difference between rings and patches. The other is in their composition. Estrogen, which is released at, this patch, which is commonly called as the orthovera patch, it releases ethinyl estradiol 20 micrograms per day. And the progesterone, which it has got, is norelgestromin. And this norelgestromin is released 150 micrograms per day. Right? Now, when I'm saying that the patch has to be reapplied, one patch is there for a week. So suppose a female had day 1 on the cycle on Monday. So this Monday she applied a patch. Then next Monday she has to apply another patch. So on Monday, any time during Monday she can apply the patch. So the patch has to be applied on Monday. It is not necessary that if this week patch was applied at 9 o'clock in the morning, then next week also it has to be applied at 9 o'clock. No. Any time during Monday she can apply the patch. So timing is not very strict with patches, number 1. Number 2, it is not necessary that if you applied the patch on left arm on Monday, then next Monday again you have to apply it on left arm. No, it is not necessary to apply the patch at the same site. Now, what are the sites at which you can apply the patches? The sites at which the patches can be applied are lower abdomen, upper outer arm, buttock and upper torso. But please do not apply the patches on breast, right? Another very important query of the patient could be that if I am bathing, if I am swimming, or if I am doing sauna, does that lead to patch removal? No, most of the times it does not lead to patch removal. But suppose, just in case the patch gets detached. Now, if the patch gets detached and you are putting it back within 24 hours, then there is no need for any backup contraception. But if the patch gets detached and you are applying the patch after 24 hours of detachment, in that case, yes, a backup is needed for 48 hours. Is that clear? So this way, yes, the patches are little better than rings, because rings, if you have, removed the ring for a sexual activity, you have to put the ring within 3 hours. But in case of patch, this period is 24 hours, right? So this is how patches and rings and oral combined pills are. Very, very important. About patches and rings, you don't need to know much. About oral contraceptive pills, oral combined pills, you need to know each and every detail. So see you in the next video. That will be on IUCD. Take care. Bye-bye.